We have another case that we want to show you. It is a requested, and I get Stella to share this case. It's another case, hospital case. Are we going to share the... Stella, the one that we're supposed to share was on?
Because of you mentioned for the equipment and how to say, then I would like to have this case before jumping to the other.
Okay.
Yeah. Because of this is a ไม่ใช่พี่เนี่ยทำไมอ่ะ พี่แชร์ไปแล้ว surgical tool ใช่ไหมครับ because of the Cheong Hospital, they mentioned one case that they would like to show. Is the sterile machine was damaged, and then they have to send the sterile machine to fix it. But the hospital technical cannot fix it for the steaming machine. It have to wait for the spare part from the abroad. Then they have to reduce the number of operation cases and send the sterile equipment to clean in the other nearby hospital. Then there's an incident reported that case of a fracture, cold fracture that have urgency to fix it, but they cannot do it.
Delay in care.
Yeah, because of case was reduced and cannot clean the equipment. Please suggest us.
This is ORIF case.
Yeah.
It's still manageable. Even, number one, they already have a process to send the patient to another hospital. That is already there. So if you don't, it's exactly the same as the hospital I did assessment on, and we published in ECRI. It's the same hospital, same problem. Their sterilizer were down. So they refer the case to another hospital to do. So that is already one of their first solution to solve the patient problem, right? When you refer a case like this, there is a delay. Then you have to look at the process of bringing in the patient. Did the patient come in by themselves is the first question we ask. Or did the patient come in from the ambulance? If the patient come in from the ambulance must have been communicated that we cannot perform level 1 trauma surgery. We have to refer this patient to another hospital. And our orthopedic surgeon will go to the hospital and perform the level 1 trauma surgery in that hospital because we don't have the facility and the equipment to deal with. And this is possible. So that communication must reach the ambulances that are servicing the area of the hospital. So that's the first information you must reach. Second thing now we come to clinical is, this case you cannot damage the patient so much is ORIF. So you can still stabilize the patient and transfer. The delay in providing care will not tremendously harm the patient. You're going to do an ORIF, you're going to fix back the patient. It has to be, you have to put implants and all that. So that's usually the case. So if they report this as delay, I like it because now I can use this justification to tell my boss, please go fix my sterilizer. Because if not, the boss will say, okay, you slowly wait. You ask the manufacturer to bring spare part, we wait. And then the boss will say, you know, today I go play golf. Then patient come in, and if you don't report delay, then the boss will say, never mind, there's no problem, there's no report. I can continue go play golf. Okay, good, you guys good. So maybe reporting will help. But in this case, for the medical device, why did we wait for the medical device to be so badly managed? Do you not have a comprehensive contract if you do not have the engineer? For managing medical device, we call them health technology management program. there is a step-by-step how you manage the medical device from the time before you buy until you decommission. There is a very strong process already available for everyone in healthcare. And there is a step-by-step what you must do to make sure that before you buy, until you install, until you commission, until you use, until you maintain, until the end of life of the equipment, what you must do. So my question is that, did you adopt that program or some of the element? And if you don't, if you adopt some, for example, then the next thing you want to identify is that what is our guideline and process and policy in managing the sterilization device?
I think so. You go fast, then just asking them that they don't understand. Maybe they don't mention because this is not my job. You can understand a sterile machine is not doctor's job.
Okay, thank you for saying that. So now I'm going to say this. Ladies and gentlemen, okay, can I ask, are you all involved in quality and risk in your hospital? Yes, no? Yes. So when you are involved in quality and risk, is fall management what is your job or not? Patient fall. Yes or no? Yes, right? Patient fall in toilet, your job or not? Yes, right? Patient fall in toilet because the janitor never wipe the toilet dry, always wet, and use chemical very slippery and never clean. Is it your job or not? It's your job, right? Even though the cleaner never clean properly, it's still your job. Yes, I agree. I also did the same job before, so I know. From the electricity, no light, until the toilet cannot use, is also my problem. So doing quality and risk, this is what we have to do. We have to look at everything. So including your medical device. Including your medical device. Because I say already, medical device is one of the 4 pillars of your hospital. If the medical device fail, your hospital fail to function. It will not be able to do the job of a hospital. In this case, it's a real life example that the hospital cannot do the job. This is just basic equipment problem. I share with you one more case. So you need for basic problem, you need to have a process to manage your medical equipment safety. And you can Google and you can read about HTM. I have a training program. I teach the big bosses how and why they should be managing medical device, because they are the one who doesn't want to listen. Usually the case. So I rather teach and share with them what we show and what the evidence say. I share with you another more recent case, which is maybe not yet happened in our region, but soon. One patient was in the ambulance driving to Hospital A in Germany. Halfway through the journey, the hospital called the ambulance. Please don't bring the patient to my hospital. Ambulance asked why. My hospital already been hacked by hacker. I cannot pull out patient record. I cannot put in patient record. I cannot use my computer system in my hospital. I also don't know my scanner and my system is working correctly or not, because my entire hospital has been hacked. There's a big skeleton, I cannot even enter my name. So please don't send the patient to my hospital. Then the ambulance take a corner and then rev and then take another 35-40 minutes drive to a next nearest hospital. By the time the patient arrived, the ambulance arrived, the patient died. That is a real delay incident case of adverse event that has truly happened. So this has not happened yet. So then many learnings that we use the case and we try to study and learn. If you are hacked, the hospital system cannot work. What is your plan B? At minimum, 2 things must happen. my critical inpatient, and my emergency incoming patient. What is my plan? Others, I don't care first. My inpatient with critical and my incoming emergency cases. What is my plan? I'm going to talk about other things here. I'm going to talk about these two very important ones. So what should I do with my patient? So what is your plan? Do you have a plan? So that's number one, that we are able to analyze from the case that the hospital didn't have a plan to manage this situation. But when they buy the new technology and the new system, wow, high tech, very fast, barcode, everything very nice, good. Then when you have a problem, then what do we do? So is it because of the hospital A, the patient turned to hospital B and died? Is it the ambulance fault? So when you do a root cause analysis, what would you find? So I have seen many of all these cases that are really terrible cases that can happen. So when reading so many of this tells me that is why we need to be very careful every step of the way. I told you earlier, we bring in new things to the hospital. We also bring new enemy inside together. The question is, you like the new solution? I say good. But do you like the new enemy? If you don't like, do you actually know what is the new enemy? If you don't even know you have a new enemy, how do you manage? How does the quality team manage? So these cases that we have, we share because it's reported. Continue to report, we want to learn. But after learning for so many years in my job, for example, I come to the point and say that enough, we need to be more proactive. Let's just not learn. We want to continue because we cannot stop the cases from happening. But let's also move forward and be proactive to find out, like for example, if you have an IT solution in your hospital, have you figured out what happens if the IT solution suddenly got hacked? What do you do?
I think hospital A have to treat the patient immediately and use the hard copy document instead of the IT, instead of medical record in the system, because the situation is crisis, and the patient is first priority of the medical staff. So that's why we have to treat, we have to care the life first.
Bravo. That's the first thing I ask. If you don't have a computer system, the doctor doesn't know how to do their work anymore, is it? Just because you use computer system, there's no more paper in the hospital anymore, is it? There's no more pen. This is the most funny thing. And why? It is not written in their policy that if they are hacked, they need to revert into plan B, which is go back to the good old days. Patient as priority. What they do is that they will go and use the new protocol because they don't want to take the risk of error, and they send the patient somewhere else so that the error or the crisis is happening there do not relate until the end, causing an adverse event from their own hospital.